Now that we've talked about the pattern of distribution of suspicious calcifications, let's go one step ahead and look inside the calcifications themselves. That is, look at the morphology of calcifications and try to understand what type of calcification morphology is associated with an increased risk of malignancy. Here again, we'll be looking at multiple cases and we'll try to understand the morphological parameters of suspicious calcifications. So let's have a look at our first case. Case number one, we've looked at this before as well. What do we see? It's basically the craniocaudal view and a mediolateral oblique view where multiple calcifications are present. We've already seen this case and we can see that there are multiple calcifications here, and here. Fine. This is something that we already know. So we'll be using the same protocol of description of calcifications as we've learned till now. So first thing that we have to tell is whether there are calcifications or not. So calcifications are present. The second important thing that we have to tell is the pattern of distribution. So if you see the distribution pattern here in this particular case, you can see a number of calcifications clustered in a small area. So we have a clustered pattern of distribution of calcifications or a grouped pattern of distribution of calcifications. Fine. Here, if we see the same pattern is being shown here, the calcifications are difficult to find, but we've seen this that we magnified the image, we could look at those calcifications. Now, this is the descriptor of the pattern of distribution. The next thing that we want to look at is the morphology. What are the most important things that we look in morphology? We look at two things. Number one is the size, the other one is the shape. Now, we have learned this since ages. Micro and macro calcifications, let it be thyroid, let it be breast. Again, the size follows the same criteria. If we see a large calcification, a macro calcification, that is typically benign. And when we see micro calcifications, it is something alarming and suspicious. So what are we looking here? If you're looking at very, very small calcifications, and these calcifications are less than 0.5 mm in size. So in other words, I can see micro calcifications, and these micro calcifications are seen in a clustered pattern of distribution. Fine. I think till now my descriptors are all correct. Now let's just magnify the image. Now I want you to have a look at the shape of these calcifications and tell me what type of shape can you appreciate. So this is the first image number one, which has been taken from the previous case as well. You see calcifications? Yes, I can see multiple micro calcifications here. Now, majority of these calcifications are showing well-formed shapes, as you can see here, as you can see here. These type of calcifications where you can see a round shape are called as either round or punctate calcifications. But at the same time, in the same case, we can see some calcifications here. Now, these calcifications are so ill-defined, having so ill-defined margins that I cannot appreciate their morphology. In other words, I cannot see the form of these calcifications. And when I don't see the form of these calcifications, it means we're dealing with something suspicious. So in English language, what is the term that we use for something which does not have a very well-defined morphology? Amorphous. So we have two types of calcifications in this particular case, that is amorphous and round punctate calcifications. We've discussed this previously also. When we have a round or a punctate calcification, that represents a more spherical form of calcification, which occurs because of calcium being deposited in the acini, which is seen more commonly with benign diseases like fibroadenosis, like fibrocystic disorders. But when we have a localized form of this particular punctate distribution, it is something suspicious. Right now, I'm more interested in this amorphous variant. This amorphous variant is in itself looking very suspicious to me. Now, let's have a look at the same case, but this is the other view. So we had the craniocaudal and the mediolateral oblique view. So this is again the craniocaudal view that I'm showing you here. What do we see here? Here also we are seeing a number of calcifications, but I would want you to have a look at this particular area or this particular area and tell me what is the shape of calcification. So you would say, sir, I can see ellipsoidal, ellipsoidal, some linear, and some irregular shape, some linear, some irregular, some linear, some punctate, interspersed. So there are multiple microcalcifications, but they're having a number of shapes. Similarly here, look at this type of calcifications. Some of them look punctate, but the others don't look punctate. In fact, they exhibit very ill-defined morphology. Some of them are amorphous, but the others are having shapes which you cannot define. In fact, I can see a number of calcifications which are having different shapes. So this type of a calcification distribution is called as pleomorphic. Again, the right word is pleomorphic because here the morphology is pleo, that is multiple morphologies can be seen. Mind you, both of these are suspicious for malignant behavior. The round and the punctate calcification is usually not seen in malignant processes, but if it's seen within a mass lesion, if it is localized, if it's clustered, if it's grouped, this rings a bell. It could be malignant. So we have had a look at three different types of calcifications: amorphous, round and punctate, and pleomorphic calcifications. Now, let's have a look at our next case. Again, our next case is pretty straightforward. What do we see here? We can clearly see a mass lesion in the right breast, mediolateral oblique view. This lesion is showing irregular margins, speculations, and also we can see some architectural distortion over here. And we also have a significant amount of skin thickening. All the major features of malignancy are present here. Right now, I would want you to look at these calcifications and tell me how would you describe it. So the first thing is, are calcifications present or not? Yes, calcifications are present. Then the second thing is their distribution. So you see these calcifications are distributed over a very small area. Look at these calcifications. This is definitely a clustered or a grouped pattern of distribution where you see more than 5 calcifications which are located within a small area of 1 centimeter. Mind you, grouped and clustered is in itself a suspicious morphology. And in this case, because it is present underlying the mass lesion, it is more likely to be malignant. Now, the next thing I would want you to tell me is the morphology of these calcifications along with the size. So when I look at the size definitely looks small. It looks less than 0.5 mm to me. So these are microcalcifications. And we talk about morphology. To look at the morphology, I would want you to have a look at the magnified image. In the magnified image, I can see a number of calcifications which are clustered, which are closely placed, but I can see the margins of all these calcifications, and these calcifications are typically looking like rounded calcifications or punctate calcifications. What are these? These are rounded or punctate calcifications. So when we talk about punctate calcifications, I've already talked about this, that rounded or punctate calcifications will be seen in benign processes. But whenever they are present in a clustered pattern distribution and when there is an underlying mass, then you know that you're dealing with a definitely suspicious morphology. So learning point in this particular case is that whenever we're dealing with microcalcifications, actually we are treating the patient as a whole. We're not looking at one important morphological criteria. So when you have a microcalcification, always interpret it with other features in the mammogram as well. First of all is the distribution pattern, which is very important, and secondly, presence of an underlying mass was the key in this particular case. Next case, something that we've already seen. This is basically the craniocaudal and the mediolateral oblique view of the breast. CC MLO, it's already written MLO here, it's fine. Now, what do we see here? We've seen this case before as well. There are some calcifications here, there are some calcifications here, and we have a mass lesion. Now, this mass lesion is very well seen. We can see some architectural distortion alongside some other opacities here, and we can also see a number of enlarged lymph nodes. Now, my next question is, do you see any calcifications? Now, based on this view, it is difficult to say whether there are calcifications elsewhere or not. I can pick calcifications here, I can see calcifications here, but there are some other areas where calcifications might be present. What is that area? I want you to have a closer look at this particular area. Do you see something white? Yes, I can see something white, but I'm not really sure. For this, I would be needing a magnified view. So whenever I am not sure whether a calcification is present or not, that can only mean two things. That is, either there is no calcification or we are dealing with a micro calcification. Whenever we have a micro calcification, it is always suspicious. So let's just enlarge this particular image. And when we enlarge this image, oh my God, what do we get? We definitely see the calcifications. And if we describe this particular pattern of calcification, how are we going to do so? This pattern of distribution, as you can see here, is more of a ductal or a linear pattern of distribution. As you can see here, all of them are arranged in this particular pattern. Fine. This is in itself a suspicious finding, number one. Number two, I want you to have a look at the morphology, something that we're discussing right now. So when I magnify it, I can see that there are multiple calcifications. They don't look pleomorphic. All of them are having the same shape. They don't look punctate because they're not rounded, but we can see that they're having a linear shape. All of them are pretty much linear. Fine. And these linear calcifications, what we call them, so the shape of these calcifications is linear, and this is very, very suspicious. This is what we learned previously when we were talking about ductal calcifications and lobular calcifications. When we have a calcification which occurs in case of tumors, it results in formation of tumor cast inside the ducts, and these tumor casts would form calcification over their surface, and they would conform to the shape of the ducts. This is the reason why majority of the ductal carcinomas in situ, without even presenting as a palpable lump or a mass, can present in this pattern of distribution. So just keep a pictographic image of this particular case in your mind. Whenever you see this pattern of distribution with or without a mass, it is always suspicious. In this case, it was easy for us because we could see mass lesion, we could see these significantly enlarged lymph nodes. But if you would have noticed, this calcification is actually present in that area where we could not see the mass. So the important point to learn is, even if you don't have a mass, even if you don't have any other suspicious feature, but if you do have this type of a calcification, which is linear, fine linear, or I can also call it a linear branching calcification. Linear branching. Why? Because if you would have noticed carefully, then you can see that these calcifications are actually branching or deviating from the central linear area. So if you have these fine linear branching pattern of calcification, these are very, very suspicious. In fact, the most suspicious for harboring malignancies are these calcifications. Just keep this image somewhere in the back of your mind so that you remember it for the rest of your lives. Now let's talk about the second important morphological parameter, that is the size. We've already discussed this calcification is so small that it cannot be even visualized by the naked eye. So it's definitely less than 0.5 mm, making it a microcalcification. So if we have a microcalcification and a fine linear or linear branching pattern of distribution, it is very highly likely to be malignant. So now let's have a look at our next case. Now, our next case is such a beautiful mammogram. What do we see here? We have a craniocaudal view and we have a mediolateral oblique view. Do we have calcifications? I think everybody would be able to identify there are a number of calcifications which are located in the breast, specifically in the upper and the outer quadrant. We'll be following the same protocol. Are there calcifications? Yes, there are calcifications. If yes, what is the pattern of distribution? So the pattern of the distribution here is going to be definitely regional. Why regional? Because we can see these calcifications which are distributed over an area of 2 centimeters, number one, and this is not conforming to any ductal distribution. Fine. Now let's talk about the most important thing. What we're discussing right now is the morphology. In the morphology, first of all, I want you to have a look at the size. So this calcification looks slightly larger than the calcifications that we saw previously. In fact, some of these calcifications are definitely more than 0.5 mm. So if I have to give a size, they are somewhere between 0.5 to 1 mm in size. And the second important thing is the shape. Let us have a look at the shape of the calcifications better on the magnified view. So when we look at this magnified image, what do we see? When we look at this magnified image and we look at the shape of these calcifications, this shape is very heterogeneous. Some of them are punctate, as you can see here. Some of them are looking punctate, while the others, they are not punctate, but I cannot exactly tell what the shape is. They look more of a triangular nature. Some again looks thin punctate here. Then here some look like linear, but they're not linear. They are rectangular in shape. So these type of calcifications where we see more of heterogeneity, but they are more than 0.5 mm, they are called as coarse heterogeneous calcifications. And mind you, it is very difficult to differentiate coarse heterogeneous microcalcifications from pleomorphic microcalcification. The pleomorphic also means the same thing, more heterogeneity in the morphology. But pleomorphic calcifications are usually smaller. They're usually smaller than 0.5 mm, while coarse heterogeneous are slightly larger. So it's again a gray area in radiology. But if you see these type of calcifications whose margins you can make out, who are slightly larger than what we typically think about pleomorphic calcification, then give it as coarse heterogeneous microcalcifications. And needless to say, these calcifications are also suspicious calcifications, and they have been given a pirates for staging because of the nature and a risk of developing DCIs in these type of microcalcifications. Let's discuss about the malignant nature of all these calcifications. First of all, the amorphous calcifications, which we looked here, where we could not see the margins, the morphology of the calcifications. So they're small, hazy, and ill-defined, and they have a risk of malignancy to the tune of nearly 20%. Now, this data may be different in different books, but they are something which is suspicious. They are of intermediate concern, and we need to report them. We need to be concerned about these. When these calcifications are bilateral and diffuse, you know that they can't be malignant. If there are clusters which are multiple and bilateral, again, they're less likely to be malignant. So if we have to place them in a Barrett's category, they will be Barrett's 2 if they are multiple and they're bilaterally symmetrical. And if there are clusters, but there are multiple clusters bilaterally, it's going to be Barrett's 3. Only when you have a unilateral cluster, and if there is a new finding which is appearing, or it is present very close to cancer. If you see a mass lesion and they're present in the vicinity, then you can directly call them as Barrett's 4. Fine. Now let's have a look at this calcification, what we talked about, coarse heterogeneous calcification, which are typically more than 0.5 mm and less than 1 mm. We have a lot of differentials like fibroadenoma, fibroadenosis, fat necrosis, and also they can be seen in this ductal carcinoma in situ, which we are trying to pick. So if you find these type of calcifications, again, be alert. They can harbor an underlying malignancy, specifically when they're clustered or when they are segmental. Again, if there is any type of calcification which is bilateral symmetrical, it is more likely to be benign. So the first thing that we're going to look in a calcification is its distribution and then its morphology. This is how I taught you this particular session. Then next, fine pleomorphic. These calcifications are the one which exhibit different forms but are typically less than 0.5 mm. They are more conspicuous than amorphous calcifications and they have a higher risk of malignancy, typically 25 to 40%. When they're present in segmental or linear clusters, something we've already talked about, they have a very high risk of malignancy or DCIS. Then the most notorious of them, fine linear or fine linear branching calcifications, which are highly suggestive of high-grade DCIS, which represents ductal casts, typically classified between Barrett's 4C to 5. And I should tell you that the risk of malignancy reaches up to 70% in these cases. So starting from the least malignant to the most malignant, I can grade these microcalcifications that we've studied in this order. So the most benign of them all are punctate microcalcifications or round microcalcifications. So usually benign, but only when they are clustered, when they're grouped, and when they're associated with an underlying mass, they may represent malignancy. They are followed by amorphous and coarse heterogeneous microcalcifications, which are of intermediate concern and may represent an underlying malignancy. Then something which is of more concern than these is the fine pleomorphic microcalcifications, which also have a very high likelihood of being malignant. And finally, the most notorious of them all are the fine linear or linear branching calcifications that we've just studied, which are most likely to be malignant. So starting with the least malignant to the most malignant, this is basically the continuum that we need to remember. So these four images actually represent the four most notorious or concerning type of microcalcifications that you should always be aware of, and you should have a pictographic memory of them somewhere in the back of your mind. So what are these calcifications? First one is the amorphous. Second one is the coarse heterogeneous. Third one is the fine pleomorphic. And finally, this being one of the most malignant of them all, that is fine linear branching. I hope you remember it for the rest of your lives. And finally, to sum up what we've studied till now, what makes a calcification suspicious? I hope now everybody of you will answer the points. Size, when it is less than 0.5 mm, or in other words, when this type of a calcification is a micro calcification, it is associated with a high risk of malignancy. When we talk about location or distribution, it's basically the ductal or segmental distribution, which is associated with a higher risk of malignancy. When we talk about the margins and the shape, we've already discussed it so many times. Starting from amorphous or coarse heterogeneous, then we have pleomorphic, then we have fine linear or linear branching calcifications, which are most malignant in the entire spectrum. And finally, clustering or grouping of any type of microcalcification should always raise a lot of suspicion. So with this, we finish our discussion on the morphological parameters of suspicious microcalcifications.